Hello everyone, my name is Sherry Barr. I am going to be your instructor this semester. This is KSPN 182 Pharmacology. My name, as I told you, my name is Sherry Barr. I'm a nurse practitioner. I work for Via Christi Health in the Neurocritical Care unit. My background is varied. I have been both a manager and a nurse practitioner in critical care most all my life. I have my master's degree through Wichita State University, and I am now having the pleasure of teaching for Pratt Community College. This is my first course to teach, bear with me, and it's an online course too. I've taken many, I've never taught one. I hope to make this fun. It's a very fast-paced course, so I must encourage you to please stay on top of stuff. Don't get behind. It'll be really hard to catch up again. So make sure and use all your resources that you have. You have these PowerPoint presentations, and I'm adding to it. I'm giving the lectures on each one of the PowerPoints. That hopefully will help it make more sense to you than just reading the material yourself. You have access to me both by email and postings on the faculty board. I'm sure you all are used to doing that. I will check that frequently. On the days I'm working, probably just once during that day, but I will try to check it at least once a day throughout the whole semester, or our whole 4 weeks actually. So let's get down to this. I want to encourage you when we have these lectures that you go ahead and you get the PowerPoints, either print them off, and if you're going to print them off, don't print them off it comes up in the slide version in your print section. Go down to where it says handouts, change that to handouts, and then if you put like 3 slides on a page, it also gives you some area so you can take notes. And I found that very helpful when I was still working and being a student. So if you'll do that, and let's just get to it now. So we're first gonna start talking about the principles of drug administration. I also have all these notes down here, so if you see me fiddling around, that's what I'm doing. Alrighty. The learning objectives for this is Unit 1. We're going to cover Unit 1 today. The learning objectives to that is we're going to discuss the responsibilities regarding administration of medications, and we're going to talk about the role that the client education plays in all this. It's a very important role that there's plenty of education for them, because that way we get compliance that they will use the meds that they're prescribed. First and foremost are the 5 rights that are now 5 plus 5 rights of drug administration. Our goal in nursing is always to provide safety to the in healthcare. This is also extremely important with drug administration. There's the traditional 5 rights, which you're seeing there on your screen. That's the right client, the right drug, the right dose, the right time, and the right route. But experience has also taught us that there's 5 additional things that are essential to professional nursing. That is the right assessment, the right documentation, the client's right to education, the right evaluation, and the client's right to refuse. So these are very, very important points. We go to the right client, that in the safety of everything, this is essential. And when you're checking to see who your patient is, you need to do 2 forms of ID. You can always ask them their name if they're able to, but what if they're comatose, or if they're unable to speak due to a stroke or something else like that, or they don't understand you, they're they speak a different language. You have to be able to identify your patient, and you also have to be careful of people with same names. You have to watch for that. You always want to prescribe the right drug, the one that was actually prescribed, and you have to think about it. Is that right for that patient, what the patient is being treated for? Are they being treated for cardiac disease? Well then, that's the right drug for that patient if it's a cardiac med. So you got to think about things like that. You want to make sure you're giving the right dose. What was prescribed? What was it written? Is it written for within certain guidelines for that drug? Are they the dosage, is that related to that patient and what we're expecting to happen? For example, if a patient has a renal function issue, their kidneys aren't working right, well, many drugs you give at a lower dosage because of that. So you need to be aware of that so that you're like a chain in that link, and you're that last chain before it gets to the patient. So you got to make sure that that chain doesn't get broken there either. You want to make sure it's the right time, because there's certain drugs you want to give at bedtime. There's certain drugs that you want to make sure that they hadn't eaten, so you want to be sure to give it before they've had breakfast. So that's the types of things you're looking at. And you also want to give the drug the right route. There's some drugs that you give orally. There's some drugs you give IV. There's some suppositories, and you wouldn't want to give a suppository to someone's mouth. So you got to think about those things. Those are the traditional 5 rights that we always have to think about for everyone. On your next slide, it talks about the 5+ rights. Those are extremely important, and this is, like I told you, these are things that have come up after the fact, after our first 5 traditionals, that also are extremely important. And the main one, the first one that I think should be listed is the assessment. You have to have collected the appropriate data before administering the drug. For example, if you're going to give insulin to a patient, you're going to check their blood sugar. If their blood glucose is 40, are you going to give them insulin? These are things you have to think about. It's also like if you're going to give digoxin. Digoxin is a drug that controls the rate in the heart. And that drug, you want to think about it. Well, if their heart rate's less than 60, would I give that drug? No. So that would be something you check on every patient before you give that drug. The next one is documentation. You always have to have the right documentation. And this is, you have to look at the doctor's order. If you're in a hospital setting or an office setting, you're looking to see, is this the name of the drug? Is it right? Is the dose right? Is the route right? Is it all been listed on there? Because they will list it, give digoxin 0.25 milligrams PO Q day or every day. So you have to look at all that. And then is there a signature? You also must document the patient's response to the medication. Say you give the patient a narcotic for a pain. They're having pain. So is their pain relieved? You also want to document, is there any unexpected reactions to the med? Do they get a GI upset, which is a common one that happens with many drugs? Or have they suddenly developed a rash? You've given them an antibiotic and now they've got a rash all over their chest. These are all unexpected reactions and you need to document those. Education is the next one, the right to education. This is like giving informed consent. The patient needs to be informed about the drug, what's that medication going to do, how does it relate to their situation, and what's its therapeutic purpose. What is the expected result of the drug? If I take this drug, what's going to happen? Are there any side effects that I need to be worried about? Are there dietary restrictions? So these are the things that we need to think about. Another one important I just thought of is lab tests. Are there lab tests that need to be taken? For example, like with Coumadin, which is a blood thinner, you have to do periodic INR checks to see how thin the blood is, because there's a window where it's working and where it stops working, or where it works too much and they start bleeding. So these are important things. Then the next right is the right to evaluation. Now you're seeing, did that drug work? So you don't just give the person a drug, patient, client, you don't just give them the drug and then not think about, okay, did it work? Did it do what it was supposed to? So that's when you want to talk to the patient and get their response to what was going on. And the very last one, it's a very important one, is the patient's right to refuse. The patient can refuse, but the nurse's responsibility is to determine why the patient is refusing. And whenever possible, you need to have a reason why they're refusing and take all reasonable measures. Maybe you need to give them further education so they can understand why this drug was ordered for them and its purpose. Maybe they just don't understand that. They still have the right that they can still refuse if they choose to. And you need to document their refusal, but you got to go one more step, and you have to follow up with that with your charge nurse or your manager, or with a prescriber. That's the best one. So if you have a patient who refuses, then you need to contact that physician, nurse practitioner, or whoever was the prescriber for that medication and follow up with them. Okay, then we go back to, this next slide goes on to talk about safety in medication administration. Back in 1999, the Institute of Medicine report came out with the article on "To Err is Human, Building a Safer Healthcare System." This report came out, and what it did was identify that there was definitely a problem within healthcare. They looked at it, and then shortly thereafter they started to really pay attention to what was happening. Because you have to think about it. There are medication errors. You have to always consider those medication errors serious. They are either serious or potentially serious. And it always involves the fact that one of the rights was missed. Med errors are, the definition for med errors are any preventable event that may cause or lead to inappropriate medication used or harm to a patient. So you got to think about that whenever you're giving it. But like I was saying, the Institute of Medicine report that came out, then they started looking at it closer and they started paying more attention to it. And what they found was that in 2001 alone, there were over 100,000 med errors reported by hospitals nationwide. Now that's a lot of errors. And that's just the ones that were reported. So there's more. The other thing that has to go into play with all of this is just in the past 30 years, there has been such an increase in the number of medications that are prescribed. There's more and more meds that come out every year that are added to the toll. So that even increases the chances of errors occurring. So we're working really hard to try to prevent that. And following all your 5 rights plus 5 rights helps prevent those errors from occurring. One of the things that they're doing is the barcoding, and that started back in 2002. The FDA proposed a rule that led to the barcoding label requirement for it was first put up for human drug products and for blood. Well, blood had been getting barcoding back since the 80s. I believe it was 83, around in that area. Those were put on because it made it safer for blood administration to make sure you get the right person to the right blood and always follow those rules, which is a whole nother situation. But then they started adding it to medications at that point. They also went to a CPOE, or a computerized prescriber order entry system, and that tries to kind of streamline, especially in the hospital settings, tries to streamline the medication processes that take place and help prevent some of the errors that do occur. They also went to electronic MARs, medication administration records. These are all databases that are encoded with all the patients' wristbands, the little wristband that they wear. There's a barcode or a little piece of information there. So it helps prevent errors by making sure you're following all those rights, that this is the right patient. Because you scan that and the patient's name now automatically comes up, and there's like different checks. There's a barcode that's on the nurse's badge. So you're scanning that, you've got the right nurse going to the right patient, and it also helps prevent errors. So there's many things that we're still trying to do. In 2004, the Joint Commission got involved, and National Patient Safety Goals came out. And the Joint Commission, they went through and were looking at some of the things like doctors' orders and all, and how they were getting confusing. And some of the errors that they looked at, they found it was simply because of their handwriting, or how someone was writing a certain letter or a certain number, and it just didn't look right. Excuse me. Anyways, so they went through and they found 5 of them that were making the most mistakes, and those are never to be used. That is U for unit, because that's what we would write for 10 units of insulin. So we don't do that anymore. IUs for the international unit, we don't do that anymore. That was getting confused with IM. The QOD for every other day, we don't do that anymore. Trailing zeros, and a lack of a leading zero. So if your number, for example, if you have a number 0.050, you don't put that extra zero on there. But you can't just put 0.05, you have to put 0.05. So you have to have the leading zero, but don't put the trailing zeros. It got too confusing. And then we got rid of MS for morphine sulfate and MSO, which is mag sulfate, because there was a lot of confusion with that. So we don't use those. Those have to be written out. If you will look in your book, in the book I have the 7th edition of your book, and if that's the same one you have, I hope it is. In Chapter 3 on page 28, you have a table there. It's 3-2 of acceptable abbreviations. That's a really good list of abbreviations, and I would suggest, make a copy of that and kind of keep it with you when you start doing your clinicals, so you'll make sure you have it with you. On the next slide there are factors that modify how that drug is going to react on a patient. In the first one there, absorption, that depends on which route it was being given. A drug absorbs, if you give it PO, if you give it by mouth, that's a much slower absorption because it has to get into the GI system to be absorbed and be used, compared to if you give it intravenously. An IV route, that drug is 100% bioavailable now when you give that drug, whereas compared to if you give the same drug through the stomach, it has to go through the stomach, break it down, and get dissolved and then absorbed through the GI tract, so it takes a little while. The next one there, distribution, that depends on the protein binders or whether it crosses the blood-brain barrier. Some drugs also can cross the placenta. Those are the 3 areas that whether or not the distribution of the drug is going to be allowed. The protein binder itself, we'll talk about that a little more later on, but it has to do with the protein stores within the patient themselves. And for example, if they have lower levels of albumin within their system, those drugs won't be able to bind. And that's something infants, they have a lower albumin level, and so they won't bind as easily because of that protein binder. Metabolism is the next one there. That's the biotransformation. And that is primarily occurs in the liver on most all medications. And so you have to think about that. There's 2 groups of people that doesn't work quite as well on. All infants have immature livers, and also the elderly, their livers decline with age, decrease their effectiveness. Plus, if they have a patient that has chronic liver disease for whatever reason, those people would also have some slower metabolism. The excretion of the drug, that's mainly through the kidneys, and again, that decreases with age. And also you get excretion through your bile, your feces, through respiration, through sweat, and through saliva. The other thing that plays into this drug response is age. Infants and elderly are the most sensitive, and that's why PEDS especially is calculated on body weight and not on age. And like again, body weight, so you have to think about the real thin people, and compared, to a normal body size. You may, if you have somebody who is very thin or emaciated, those people you have to think, and maybe you have to give that drug a little differently than you would give it to a normal size person. And also there's a lot of different drugs that you have to think about in the obese that you have to adjust. Some meds are not based on normal BMI, but some are, so you have to think about that. And then toxicity, that is one of the first adverse symptoms that occur, and it increases with the young and the elderly, or with people with renal or liver problems. So those are just some of the issues. On your next slide there are some more factors that modify your drug's response. That's your pharmacogenetics. There is an influence of genetic factors on the drug response. For example, if a mom has an allergy to some kind of medication, there is a chance that that child may also have developed that genetic factor that causes that. And then your route, like I said before, your IV versus PO, the speed of which it's going to actually be absorbed. Time, okay, is your stomach empty? when you take that medication. If it's empty, it may absorb faster, or maybe you need to take it after you've had something, so it doesn't affect the stomach wall and cause some issues. Then there's some emotional factors that play into this. Were suggestive comments made about the medication prior to it being given, and is that playing any effect on how the results are? You have to look at the pre-existing disease states. Do they have liver disease, kidney, heart disease, any circulatory problems, or GI disorders? For example, diabetics, you wouldn't want to give them meds that contain a high sugar content because it's going to mess with their blood glucose. Their drug history. Did they take anything similar in the past? Is it a medication that they're used to taking? So then, have they developed a tolerance? And a tolerance is when the ability of the client to respond to that particular dose might decrease over time. You see this a lot in different pain medications. So then what you might have to do is give a combo drug to try to override that problem that you have developed. Then there's always the cumulative effect. When the drug has been metabolized and it's excreted and metabolized slower than it's being administered. So then you start having some side effects from that. Maybe now they're really, really sleepy when the drug was working at first, but now their kidneys aren't getting rid of this drug, so they're staying in their system longer. So now it's starting to have a problem that way. There's always the drug-to-drug interactions that take place, and that's because the drugs may be competing for the same receptor sites, and we'll talk about that more here in a little while, make that more understandable. Then you have your food and your drug interactions, because some foods may speed, some foods may delay, and some may just block the absorption of that med completely. So then that's an issue. On your next slide there, we'll get into the forms and the routes of these medications. Tablets and capsules first. You don't want to give those when somebody's having a upset stomach. If they're going to think they're going to throw up, that med's not going to stay in there long enough to do any work. You also have to think about, do they have a gag reflex? Some of our patients, after they've had a stroke or something like that, they don't have a good gag reflex or a good swallow. You never give a tablet to a patient who's comatose. So that should be pretty obviously why. And don't mix pills with large amounts of foods or beverages, because if you mix it in, you've got a big plate of potatoes there, mashed potatoes, and so you put their pills in them there so they'll take them, swallow them better. But if you do that, they may not drink or eat it all, and then they don't get the med. So if you're going to mix it like in some applesauce or pudding or something, or mashed potatoes, you just use a small amount, like an ounce, and then mix it in there just to make it so they can swallow it better. And never put meds in infant formula. Never do that. And always, on certain drugs, you can crush them up to put them in stuff, but if they're enteric coated or if they're time released, never crush those pills. If they're like a SR after the name, or ER, like that's extended release or sustained release, don't crush those pills. Okay, any foods that or any meds that are irritating, you want to be sure to give those with filled food. For example, NSAIDs, any of those, they can be irritating the stomach and cause actually bleeding in the stomach, GI bleeds. You want to be sure to give those with some milk or bread or something to kind of coat that stomach. Then you got to think about drugs. Some of them are sublingual, which means under the tongue, or buccal meds, and those are in the cheek form. Those you want to let them stay in place till they're completely dissolved, and then don't give them anything to drink until that is completely dissolved. We want to encourage people to use child resistance caps on all their medications. That helps prevent any people getting into them that shouldn't. And then there's the liquids. We'll get to the liquids. There's several forms. The liquids are elixirs, which is usually a sweetened formula. You have emulsions, and those are really two liquids that aren't stable together, so you got to shake them up real good and then hurry up and give it before they come apart again. And then you have suspensions, and those are when there's just like particles in liquid that don't dissolve, but you want to suspend them in that liquid before you give it. So always read those labels to see if any of that needs to be diluted or shaken. And also, a lot of those have to be refrigerated after you're done with them. Then you get to your transdermal meds, and those are medications that are stored in a patch form, and they're absorbed through the skin. They get a systemic effect that way. You got a lot of your pain meds are that given that way. You have cardiovascular meds given that way. Some of your neoplastic meds, they're given that way. Hormones is another one. These provide a more consistent blood drug level. The one thing you got to remember about it is when you remove the patch, always remove the patch before you put another one on. Rotate your sites. Clean the area before you put another one on. Say I had a patch on my chest here, take it off, wash that area. Okay, now wash this area and put a new patch on this one. So read your directions and never ever ever cut these patches up. I have seen that happen. It's not good. You don't get the right amount of drug. You can't be consistent that way. Say if you were on a patch and it was like a 12 milligram patch and now the doctor has changed you. He wants you on a 7.5 milligram patch. Okay, you can't go home and cut that in half and think you're going to be okay. You now have to get a new patch. So they're made that way. Then we get to the topical meds. And these can be applied to the skin, never with your bare hands. You always use a gloved finger, a tongue blade, or a Q-tip. And you always wear gloves when you're doing this. And don't double dip. Say you got your Q-tip and you take your meds and you put it on the patient. You don't go back and get more and put it on. You get a new Q-tip or tongue blade each time. Okay, let's go to the next one. Other forms and routes. These are talking about insulations. This is in the eye. You've got a nice example there on box 3-4. So if you can look at that. I see here. It's on in the book I have. It's 4-4. This is for drops. When you're putting eye drops in, you always pull the eyelid down, and you're exposing that conjunctival sac in there, so that you can put the drops right there, not on the eyeball itself, but down in the sac. And then when they close their eye, it'll get on the whole part there. Liquid meds are administered in a drop. They can also be ointments or they can be sprays. And on your next slide there, which is on figure 4-5 in your book, that's showing how you put the ointment. Again, you pull that strip down, and what you want to see is that conjunctival sac, and you're going to put like a 1/4 of an inch wide strip right on that inner sac there, and then you're going to close the eyelid. You want to be very careful not to contaminate the tip of your dropper or the ointment, the tip of the delivery system that you're using with that. Because say they have some kind of infection within your eye and that's what you're treating, so you're putting the med in, you don't want the microbials to come back and get into the medication and be able to transfer it on. So now maybe they had it in this eye and now they're going to have it in this eye too. So you have to be thinking about that. On your next slide there, we're going to talk about your eardrops, and there's a cute little way to remember this. If a child is 3 years or younger, you pull the ear down, so you're pulling it down, and that opens up so that you can see inside there. Anybody who is 3 years and older, you kind of pull up on the ear. That's just the way there are, as we grow, how things happen in there, and it opens up so you can actually visualize down through that ear canal. Always wash your hands first. Use medications at room temperature. Tilt their heads slightly towards the unaffected side so you can have better visualization, and then keep them tilted for 2 to 3 minutes there to allow that medication to get into all the places where it needs to get to be able to do its work effectively. Again, be very careful not to contaminate that dropper. All right, your next slide there is on nose drops. Nose drops and sprays. So on those medications, always wash your hands. Have the patient blow their nose prior to administering the medication. If the infection is in their frontal sinuses, in this part here, and not so much in the back, then you want to have them tip their head up, their frontal, especially like if it's up in here. If it's down, if they're having a lot more down in here, then you kind of want to go to the side that's affected. So if it's a frontal, you have them tilted back. if they're having more sinus pressure on this side, you kind of have them tilt this way. And anyways, you then follow the directions on the spray, whether it be the dropper or a spray, and then you have them keep their head tilted in that same position for about 5 minutes till that medication can get in there and work really well. On inhalations, that is on your page 39 in your book, is where you'll start looking at this. Inhalations are handheld. It's a very fine size particles are in a mist delivery system, usually from a multi-dose inhaler. It's an MDI, they call it. That's how they're delivered. You can follow the directions on theirs. A lot of times a spacer is used to enhance that delivery, especially like children or people that have a little trouble. They have those inhalers, and then there's a spacer chamber that's attached to it. So then the particles all get put into this chamber. And then when they inhale, all the particles then come in. They don't just miss them and they go flying out the sides of their mouth. If you ever see anyone use an inhaler that's not used to, you'll see that happen. NG tubes. Now with NG tubes, there are certain rules you have to always do. You have to check the proper placement of the tube prior to using that tube. So you've got to make sure it's where it's supposed to be, not in their lung, not in their esophagus, but down in their stomach. You need to pour the drug into a syringe without a plunger or a bulb. You know, they have the plunger syringes or they have the bulb ones. You want to make sure and remove that. You release the clamp on the tube after you've got that tube on there, and then you allow the medication to flow by gravity in through the tube. Then you flush that tube with 50 cc's of water. Then you can clamp it and remove the syringe. So there's steps to that, and I'm sure in lab you'll get to have a chance to do that hands-on. In suppositories, they can either be rectal or vaginal. You always lubricate your insertion tube or insertion device, whether it be a gloved hand or another applicator. These medications are usually wax base or something that can melt easily with heat, so you keep those refrigerated. You always explain what you're about to do to the patient before you proceed, because you know it's invasive. You have them, when you're doing a suppository, you have them lie on their left side and breathe through their mouth. That helps relax the sphincter there. Then you insert it and make sure they stay lying there for about a good 20 minutes while that medication melts and becomes absorbed. In a vaginal suppository, then you're in a lithotomy position, and you use an applicator. Again, you've explained this to the patient what you're about to do, and then you always provide the client with a sanitary pad afterwards, just to be nice, help them stay clean. The other route that we're talking about is parenteral. There's a lot of safety factors that have been added to the parenteral dosing of medications, to needles, to needleless systems. It's to help or to decrease or try to eliminate, but at least decrease needle sticks. There are some things you just have to use a needle, but the whole thought process behind it is to prevent blood-borne pathogens from entering people who don't have it yet. For example, hepatitis or HIV. So that's why there's been a big push for all these needleless systems that have made a lot of improvement in needle sticks. Then we get into some of the different types of using the parenteral route. The first one there is the intradermal. What you got to remember, you have to think, where are you putting this medication? So what you're doing, intradermal, you're just putting it just below the top layer of skin there. So you want to think, you're just going into the epidermis. There's just a small little layer there. So you're going to be looking for local effects. This isn't going to be something that's going to be widespread. You're going to be putting it in a very small area. So it's going to go the local effect of there, not systemic. So you're only going to use a very small amount of liquid to that site too. Generally speaking, you're only putting in there like a 0.1 to about 1 mil underneath there, 0.1 mils underneath the skin. things of that nature is like TB tests, immunotherapy testing for cancers, allergy testing is done that way. You're also using very, very small needles. You're using like a 25 to 27 gauge needle on those patients. Then you go to the next step, that's the sub-Q. And the subcutaneous, you're getting into the subcutaneous layer of skin, which is underneath the dermis. So you're still using a smaller gauge needle, but you're giving a little bit larger amount of fluid. Usually like a 0.5 to 1.5 mils are injected in that. This you're looking at, in this, on your next slide you'll see there, these are the areas where you can give the sub-Q shot. What you're looking for is an adequate fat pad for that to set in. So that's your abdomen, your upper hips, your upper back, your lateral arms. You're using a 25 to 27 gauge needle again, and these are things like, your insulin, these type of medications. Then you get into your intramuscular meds, and those meds, they're given into muscle mass. These are looking for a more systemic effect. You're giving a shot like a pain medication. So you're wanting that pain medication to be systemic throughout the system to help relieve that pain wherever it may be. So this is a more effective for a rapid results of the drug. Not as fast as IV, but rapid. This can also be used for drugs that are irritating. These are things that are like a solution in oil or an aqueous solution that's kind of got some thick potential to it. So you're looking for a good muscle mass with a minimum of major nerves and blood vessels, because when you poke that needle in there and you've got a blood return, you've gotten a vein and not a good muscle mass. Your muscles that you're looking for is your ventral gluteal. You're using a 1 to 1.5 inch needle to get to that. You can also look at your dorsal gluteal, and there's pictures on these that go all as you go through these next few slides. You can also use your deltoid on a person who has enough muscle mass there. And in pediatrics, though, you always use the vastus lateral. And that's also one we use on very thin, like tiny little ladies that don't have much there. Then we can use that one, that area to inject. And as I said, if you look through the next few sheets there, your next slides, you'll see those sites. And they're also well illustrated in your book there. The next one is they talk about the Z-track. Now this was something, we don't use it that much anymore. It's very good for meds, though, that cause skin discoloration, especially like your irons. And that is a technique where you're pulling back the skin, then you're sticking the needle in through that skin, giving your injection, and it's just as soon as you're pulling it out the needle, you're letting go of the skin. And so the thought process behind that is that it kind of seals it so that the stuff cannot come back up to the top surface. And like I said, iron is one of those where you would want to still use that because it does discolor the skin. The next one is your IV, and that's the one that we talked about. Generally speaking, you have an IV site present, and those IVs are placed, and it shows you your different veins here on this slide. You have your median, which is your antecubital, right in the middle of the bend area. That's a good one, and it's easy to get to. You also, there's multiple veins on top of the hand. You have a radial vein, which is a good one. It's easy to get to in the lower part of the arm. And then there's the cephalic and the basalic vein up there near the top of the arm. So there's some good sites there to get an IV in. These are very rapid onset of medication, can get to those. Now, just a little bit more about your parenteral medications that I do want you to remember. Do not use your Doris gluteal in children, so that's just something just to remember. The ventral gluteal for IM injection is very good in adults and toddlers, but only if it's a walking toddler. If that toddler is not walking, use that vastus lateral. That's the preferred site for children that are not walking yet. And when you're giving kids, pediatrics clients, you got to think about that. They have increased anxiety. you're a stranger to them. Try to be non-threatening. They may be thinking that all the stuff that's happening to them in the hospital is punishment, especially the ages 3 through 6. Include their family, include their people that they trust to be a part of the health care that's going on. They also have a real fear of being mutilated, so you want to try to use the least intrusive routes whenever possible. So a little bit on your equipment. Always make sure that you know your technique before you go in the patient's room, and then make sure you educate the patient about what's about to happen to them so that they know it. And always have your equipment. Make sure you have the right needle for what you're about to do, for the right volume that's going to be delivered. Use a filter needle when drawing up meds out of a ampule, and then change needles and use another needle to actually give the medication. Well, we're moving right along here. Okay, now let's talk a little bit about the nursing process. Now this is important. This is your nursing process, and you surely have heard of this before, but now we're going to relate it to medication administration. Your assessment, okay? The assessment of your patient, you need to look at things like their vital signs, lab results. Do they have an allergy? Do they have a drug history with this? Are they capable of following a regimen? Say they're going to go on a medication that they're going to have to be on now for a while. Are they able to understand and capable of following that regimen before? And what do you need to do to help them be able to follow that regimen? So you have to think about all those things and to relate it directly to the patient that you're dealing with. Some of the nursing diagnoses that come from that is the risk of injury. Also knowledge deficit. So these are some of the things you have to think about when you're doing your assessment. Planning. You have to think, okay, what is my goal for this? And what might be some of the adverse reactions that might happen? Because you've got to plan. You want to know what your adverse reactions could be before you give the drug so that you'll recognize them immediately when it happens. You also want to get your ID information. Make sure that you know you're giving the right patient the right drug. And you want to promote adherence. You want to promote that they will continue to take this medication as long as they need to. For example, you'll send someone home on some antibiotics and you want them to be on it for 14 days and they stop it. They feel better after 4, so they quit taking it. So you need to plan how you're going to make sure that this patient understands all this. So you got your plan in place. So now you're going to go do your intervention. This is where you prepare your equipment, you wash your hands, you check allergies, you read your drug labels, you read them at least 3 times, you look for an expiration date on that medication, you be sure that your drug calculation is correct, and if need so, you check it with another RN to verify. Make sure that your drugs were being stored properly before you gave it. So now you're going in and you're going to teach this patient. You have to do some general education for this patient about this medication. Do they need, especially if it's going to be self-administered, do they need to understand that you don't need to eat this, you need to take food beforehand, or take this on an empty stomach, or take this at bedtime? So they need to understand that. And then you have to evaluate. That's the last step in the nursing process, is you always evaluate. You have to see, was the drug effective? Did it respond like you thought it would? Does your patient understand what the drug was given for, and are they satisfied with the results? So that's the full process, and it's in medication administration of using that nursing process. So now let's talk a little bit about all these safety issues that we have. All these technological advances that we have made in the last 20 years, they really have shown that there's a true push to be as safe as we possibly can with our medications. There's an increased accessibility to sites for their patients. It has promoted client mobility. I mean, our patients aren't having to just stay in their homes now. With the way technology has gone, our patients can actually get out and move around and still get the cares that they need. There are even cruise ships out there now that people with dialysis don't have to be trapped at home. They can actually go on a cruise. So there's a lot of technical advances that have been made to help improve our clients' lifestyle and mobility. We also have a lot of ways we have gone about to improve client adherence. A lot of that is with education. We have people there. If you teach them and make sure they understand the whys, the wheres, and the what fors, then you have a better client adherence to that regimen. Now we have a question there. Question number 1. The nurse is required to chart the client's response to the following groups of medication, except, so which ones of those do you don't have to follow up with a response? Which one do you expect not to have to do that to? Well, A is a narcotic, so you have to chart, did it work? Was there pain relief obtained? And B is an antiemetic, so did it work again? So are they still nauseated? Are they still throwing up? And number 3 is you have to document if there was any unexpected reactions or report if there was any. So the answer is D. That medication lowers cholesterol. So you don't have to write that because you won't know that until they've been on it for a while and then they get a lab report that tells you how their cholesterol, if it has improved or not. And then your next one, it's explain the purpose of self-medication administration. So it's just another question, and you guys can kind of think about that a little bit, and then on the next page there, it'll give you the correct answer, which is to promote client participation in management of medication administration during hospitalization. This experience prepares for management of medications in community settings, home, school, workplace. It empowers the client to be more effective in the management of therapeutic regime. All right, that's our first unit together. I hope this was helpful, and take a little break and then we'll get back to the second portion of Unit 1. Thanks.